Welcome to episode 38 of America in Crisis, Breaking the Cycle of Addiction. My name is David Hunt, and I am your host. Please set your DVRs to record. The show could save your child's life. According to the Department of Health in Massachusetts, we have had over 2,000 opioid-related deaths in 2023. Today we will be talking about the latest deadly substance found in opioids, xylazine. The street name is Tranq. It is an animal tranquilizer. It was never intended for humans. It is found in 8 out of 10 opioids that contain fentanyl. Over the summer, I attended a webinar put on by Boston Medical Center about xylazine. With what I learned, I put on a presentation for the Middlesex District Attorney Marion Ryan's Opioid Task Force, and last week, a live presentation for the Beverly Emergency Management Agency and the Beverly CERT team. If you think you are buying only heroin or an opioid, you are so wrong. Our guests are experts in this field. We will hear from the people that actually know what they are talking about. Today's guests are Officer Ted Lane of the Beverly Police Department and Lisa Maccario of Beth Israel Lahey Behavioral Health. I met Ted on a training webinar he taught last week, and I knew he just had to be here today. Officer Ted Lane is a certified paramedic for 29 years. As a paramedic, Ted worked for private ambulance services and hospital-based services, as well as a flight medic for Boston Med Flight. Ted has been full-time with the Beverly Police Department for 19 years. Ted is trained in mental health, first aid, and crisis intervention team, known as CIT. Ted is trained as an instructor for CIT. Ted also serves on NEMLIC, Critical Incident Stress Management Team. Lisa Maccario is a clinician for Beth Israel Lahey Behavioral Health Services. She is currently embedded in the Beverly Police Department Community Impact Unit, where she co-responds with law enforcement to provide behavioral health support and follow-up care to residents of Beverly and Ipswich. Lisa has 25-plus years experience in client-directed, trauma-focused crisis intervention, stabilization, and treatment, and a bailiwick that includes community-based program development and implementation. She and Ted are both certified CIT instructors, as well as CISM with NEMLIC response. Lisa also works for Riverside Community Care, Incorporated, with their Trauma Response Center, and with 9Wise Incorporated as a trainer consultant. Lastly, she sits on the advisory boards for Essex County Outreach and Northeast Center for Occupational Health and Safety. Ted, Lisa, welcome to my show. Ted, let's start with you. You've got quite an impressive bio and introduction here.
Thank you.
Now, you've been with the Beverly Police for 19 years. How is the drug crisis progressing year to year?
I think probably about 10 years ago we saw a spike in some deaths and everything, and a lot of that had to do with the mixture of fentanyl into the drug stream. Right now, heroin almost doesn't exist at all. Fentanyl has pretty much taken over all the deaths, so the drugs are much stronger. So we've been needing to use more Narcan to reverse the drugs, so we're seeing a lot of that. We've also started to take more of a proactive approach. Police officers have always been reactive,
yes,
and we've always, treated the overdose at the scene, and then we kind of separate ourselves from it. We're also not arresting people for possession of needles. We're not arresting people who call 911. Okay. So it's safe to call 911 if you have an emergency and you need something like that. And then we're also starting to get a little bit more into the preventative part, okay, and also working post-overdose with recovery coaches and harm reduction coaches. So we're kind of thinking a little bit more outside of the box as police officers, which is a little bit of a stretch for some of our guys, but we're getting there and we're making progress. And I think that's the only way to handle this problem, because you can't just treat an overdose and then expect it to go away, because it's just going to repeat itself.
I noticed in your resume you're also an instructor, CPR, Narcan, all that. Have all your officers been taking that type of training?
Correct, yes. So as a paramedic for almost 30 years now. Prior to getting on the police department, I had 10 years working as a paramedic. So I'm one of the lead instructors along with Lieutenant Pangiwani, who's also another paramedic. And we have a couple other instructors on our department, but we do all the CPR, first responder, AED, and Narcan instruction for the department.
And I know how ambulances do get tied up, especially after the tragedy in Winthrop, when the ambulances are out on a call. And it's nice to know your offices can get the ball rolling until the actual transportation gets there.
Absolutely, yeah. We're often the first ones on scene, so having the AED or Narcan can make a big difference in, when things are time sensitive.
Especially with the Narcan, I understand that'll revive them actually on the scene rather than wait to get it to the hospital.
Yeah, it's a pretty amazing drug when used appropriately, and it's not an end-all be-all type thing, but it certainly has saved many people.
It's nice to know with 10, 20, 30 cruisers running around compared to 1 or 2 ambulances.
Right, yeah.
The chance of getting help right away.
Yes, yeah. Definitely. All of our cruisers have Narcan in them, along with AED, so any officer, not just myself or anything, but all of our officers are trained. And it took a little bit of a curve to get used to it, but I think right now our officers are very quick to get out the Narcan and assist.
I really don't know one officer that would sit there and just watch and not do everything in his power to
Absolutely
help
not.
save that life.
Correct.
Now, you're part of the Community Impact Unit. Can you explain to our viewers what that is, please?
So the Community Impact Unit is a part of the police department that's trying to take a different approach to dealing with police type issues, and we're also dealing with all community issues. So our goal is to be there for the community be able to reach out to us, also deal with a little bit of the more vulnerable population in the community, our unhoused, our mental health, our substance use and alcohol use disorders. But in general, we kind of cover everything. We work with different units or groups within the city. We work with the public health department on things like hoarding, if there's someone who has a hoarding issue. So I have my particular niche, and that's obviously working with Lisa and doing a lot of the mental health stuff, the substance use, alcohol use disorders. But we kind of cover a lot of area.
And how's that made a difference in the community?
I think people are much more willing to approach us and be willing to reach out for help. Working well with the unhoused population, create a good rapport with them, try and get them assistance in anything that they're willing to help with. I think in the mental health field, we have a lot of patients or clients that we see kind of repetitively, so they get used to seeing our faces and training our officers. So I think it just makes the police department a lot more approachable and not always like, they're here to arrest us, or they're here to, they can call the police. It doesn't have to be an emergency. It could be something that they just need assistance with.
I mean, I was growing up, the police basically had one role. If you did something wrong, they would come and either teach you a quick lesson right there on the spot, read you the riot act,
Absolutely.
or take you away.
Yep.
And that was their role, basically.
Yeah.
And now you're responding to emergencies, you're doing medical. How is this difference in the 10, 20 years since I grew up made a difference in the community with everything that you are offering to the community?
I think one of our big goals, and like you said, that was the same when I first started, but our goal, especially with mental health and substance use, is jail diversion. Our goal is not to send people to jail, not to arrest them, and that's difficult for some people to understand, and even some of our officers to take that approach and everything, but our goal is to get them the help that they need, get the services in place, avoid transporting everyone to the hospital. Because before, especially with mental health, police officers' only option was an ambulance to the hospital. Now we can co-respond together. We can reach out to other facilities that might be involved with the party, if it's our community behavioral health centers or different programs that the people might already have in place. We can facilitate and kind of fill in some of those gaps and cracks and prevent someone from having to go to the hospital or having to get arrested and go to court and jail and have to go through that route.
What other things in mental health is so important that the role you're doing now compared to what you did 20 years ago?
I think there's a lot more of it. COVID certainly, we saw a spike in mental health issues with that. I think it's just, and we've seen other instances where in the United States where people with mental health issues and it's gone poorly. And our goal is to prevent that from happening, to be able to go in, slow things down, de-escalate, not go hands-on, not have a bad outcome, try and get people the services and things that they need in place, as opposed to the old-fashioned, police come in, we're gonna arrest you, handcuff you, and type of situation. So I think it's important to have that attitude going in, being able to de-escalate and just slow everything down, just be calm.
Now, we spoke about the first day that your officers have been trained in. I know there are other courses throughout the years that are being offered to the police department. Can you tell us what some of those other courses are and what type of training that they actually have in addition to just the first aid.
So along with the mental health
Yeah.
portion of it is a course called Crisis Intervention Team,
Yeah.
and that's something that we've been working on, and we've both gone to training and become instructors in Crisis Intervention Team. And it's a 40-hour course when we teach it, and the whole purpose of that is to train officers in a very brief overview of all mental health disorders, and that can include developmental disorders, autism, other things, just so that officers are kind of aware of the different spectrum of ways people might respond. And a big portion of that is de-escalation, slowing things down, talking to the person, introducing yourself, saying your first name, coming in and saying, instead of wearing a big bulletproof vest, and this is what I wear when I go out to a call. I try and keep it as low key as possible. I go in, I say, hey, I'm Ted, what's your name? And people are like, oh, okay. And it's kind of like disarming and just kind of bringing everything down a little bit. So our goal is to train a good portion of our officers. We're not shooting for 100%, but we're going to work within our department, and we're hopefully doing most of Essex County, and to train them and create a team approach to mental health.
Now, a lot of times the police do arrive first to the medical services. If I've been down on the ground, not breathing, no response, basically walk us through what that officer can do for me? What's he trained in?
So we're trained in CPR, so the first thing would be to determine whether the person is responsive, breathing, has a pulse. If there's no pulse, they would go right into CPR. We have the AEDs. Our officers are great with that. Took a little bit of a learning curve, but they've been in the vehicles for well over 10 years now. So AEDs are like and if the person is breathing, we're trained to recognize signs of an overdose, the pinpoint pupils, the decreased respiratory rate, the cyanosis of the lips or blue fingers, and immediately administer Narcan. And the other big thing that I push with all my officers is ventilations.
Absolutely.
So everyone's trained in how to use a bag valve mask. Narcan, and we'll talk a little bit more about it, but there's some other, Narcan is a great drug and it helps reverse narcotic overdoses, but there's other things mixed in sometimes, alcohol, benzos, xylazine, so it's not always going to be the end all be all. So I always emphasize airway, ventilation. We carry oxygen, we carry bag valve masks.
Wow.
We're
You guys are prepared. Yeah. Now you're also with NEMLIC. What do you do with the critical stress with NEMLIC?
So the critical incident stress management team is through the New England or Northeast Law Enforcement Council. I'm trained, and Lisa's also trained in group and individual not therapy, but what's the best word? Group and individual treatment. And so our goal is we do different things. We do a diffusing or a debriefing, and we basically come in after a critical incident. So a police department within our catchment area has a really bad accident. Maybe a pedestrian child is killed, and it really affects the officers. Seeing that stuff over and over and over again, we've learned that it does affect us. We are people. We feel, we grieve. So in order to prevent that, we have these debriefings where officers can say in a safe environment how they feel, what bothered them. We talk about them. It's not a critic. We don't say, oh, you did this wrong or this right or anything. It's just a time for officers to be able to get that off their chest and feel a little bit better about it afterwards. Right. And if necessary, there are resources for further treatment, and we work with clinicians, officers, and we also involve clergy with that too. Right.
Now, when I first was talking to you, I'd asked you to send me in a bio introduction for about 30 seconds. And Ted sent me in a 7.5-minute bio. So there's a lot of stuff on there that obviously I did not come with the introduction. I think that's important that you'd just like to share with our viewers what your level of certifications are, some training you've done, you graduate. If you could take about another 30 seconds.
30 seconds.
I know I owe you 7 minutes.
Yeah. Real quick, my BS is in biology. I kind of was thinking the pre-med route, but after college I went to paramedic school at Northeastern, graduated from Northeastern in 1995, January 95 as a paramedic. Worked as a paramedic for 10 years, then I used to work for Boston Med Flight, which that was an amazing job, very educational, above and beyond, even like as a paramedic, the stuff that we learned. And then I joined the police department and got my master's degree in criminal justice with a certificate in forensic psychology. And from there, just have continued to go on to take more continuing education classes, the GRIN classes, the CIT classes. It's just, that's my niche. The mix of police and paramedic kind of make me fit into that category, I think, a little bit.
Well said.
Yes.
Thank you.
Short and sweet.
Yeah, short and sweet.
I had the theme from Jeopardy going through my mind. It's 30 seconds. I'm cutting it right there. Okay. Now, Ted, Beverly seems to have a lot lower number of incidents, overdoses, or fatalities than a lot of the surrounding communities. What can you base and attribute that for?
Well, I think honestly part of it is we are fortunate in that our numbers are lower. We have less overdoses. We're smushed in between Gloucester and Lynn and Salem, some bigger cities that have a much higher problem. So part of it I think is just our population. So we're fortunate in that. I think the other thing is, we've been trained in Narcan, so preventing deaths that way. And I think our new approach of just doing follow-up, prevention, working with harm reduction and recovery services. So we work with One Stop out of Lynn. They're our harm reduction group that we go out with, and we work with Essex County Outreach, and they're our recovery group. So we have people with lived experience that I go out with, and Lisa joins us sometimes, and we can go in and talk to somebody who's had an overdose and see if they're ready to take that next step. So I think as a police officer, we've always just kind of responded to the immediate emergency, but now we're trying to branch out and prevent and follow up.
Okay. Well, you're not off the hook yet, but I will be coming back to you.
Okay.
Lisa.
Well, hello, David.
So you're with Beth Israel Leahy Behavioral Health.
I am.
What do you do there? Other than the 6.5 minutes you sent me in on the bio.
I'm sorry.
Another 6.5 minute bio.
I've worked for Beth Israel Leahy Behavioral Health for 10 years. In fact, it'll be 10 years on Saturday.
Congrats.
Thank you. It's been a great run, but in 2018, I've done several different roles, but in 2018, the City of Beverly contracted with Leahy to provide a jail diversion clinician. And with my previous training and experience, that was the role I applied for, and this is the role I got. And so I've been doing it for 5 years, and we actually have 7 clinicians that do what I do now.
Wow.
Which cover 16 police departments collectively. We have a manager, Danielle Sogi, who has been doing this role 10 years prior to me in Salem and Danvers.
Okay.
So it's expanding. Lee's committed to community work. They've always been committed to community work, and this is just another arm of that.
And what is the jail version that you did at the beginning you mentioned?
The jail diversion?
Yeah, what is that?
So
I know what it is, but let our viewers know what that is.
Yeah, so jail diversion, unfortunately, I feel like it is a title that is a little bit misleading because it's not just about diverting from the criminal justice system. It's also about meeting people where they're at, helping them receive services they need so that their problems don't repeat, and that they're able, that they feel like they're being helped instead of penalized. We do divert from the criminal justice system. That is our primary goal. Our other goal, and that means if someone's committed a crime, that's up to the police department to decide if this crime is something that they need to move forward. But if it's a mental health or substance use driven crime, there's better interventions for prevention, right? And it's hard to measure prevention, but as you can see, we are reducing our numbers of overdoses because we're doing preventive work, outreach, and that stuff. So.
Now, obviously, Ted brought you along for a reason. This was going to be a show on xylazine.
Yep.
I was trying to find someone that could talk to me and our viewers on xylazine. It took me forever to find somebody, and that was Ted. And as soon as I asked him to come in, he said, I work with all these programs, and you've got to bring Lisa in. We work together. And it was a package deal. He wouldn't come in without us. So.
We are a package deal. It's funny.
So I'm going to ask you, how do you interact with the Beverly Police Department? What is your role in daily interactions with them?
So I am embedded into the Beverly Police Department, so I am part of the Community Impact Unit.
Okay.
I also cover 5 other police departments in the North Shore.
Would you like to elaborate on those?
So Chief LaLasha for Beverly was sort of spearheaded and drove this with the Gloucester Police Department. And so we collectively address concerns in Gloucester, Essex, Manchester, Rockport, Ipswich, and Beverly. So there's 6 of them.
Okay.
I am embedded into the Beverly Police Department. I provide follow-up to the other departments while we're waiting to hire a second clinician.
And how do you interact with the public? Is your role on the Beverly Police?
So A call will come in if I'm on shift. So
Okay.
what's difficult is there's 3 shifts, 24/7 in policing. So events happen frequently when I'm not there.
They haven't cloned you yet?
No.
I always say we need 10 of her.
Well, how many officers do we have? We probably need that many. But in any event, if there's a call that comes in, dispatch will send us out to co-respond with the patrol officer,
Okay.
who arrives first. And when we get there, I let the police officers take the lead. They assess the situation at safety. Safety's primary.
Yes, of course.
So for everyone, for the person that we're treating or we're meeting, the police officers, myself, the community at large. It's all about safety. So when we get there, it's safe for me to assess the psychological need, right? So I will do in the field while Ted stands by and make sure things remain calm and safe, along with the patrol officer. Sometimes they leave if it's taken too long, but for the most part, it's about safety. So I will assess the person's need psychiatrically, and I will create a disposition. So do they go to the hospital? Is this a Section 12 where I have to send them against their will because they are just so unstable and I can't stabilize them in the community? Or people go voluntarily. Then if they don't go to the hospital, we send them to the community-based health center, which now are across the state. It's a great organization. I think it's a big step forward in mental health. Or I connect with their already in place providers. So I work with DMH, and their contract is with Elliott Behavioral Health.
Yes. Oh, yeah.
So those clinicians work with a lot of people that have mental health. So I will call them and say, this is what's going on, what do you recommend? And they'll either say, we can come out and help stabilize this, or please, you need to send them to the hospital, whatever. So we work with providers to stabilize in the community as best as possible.
What other trainings have you had that you do for this intervention? You had a very impressive bio. Here's your chance to get it out. I wasn't going to read 12 minutes.
So I've been doing trauma response from the bulk of my career, 25 plus years, I hate to say, but yes.
She started when she was very young.
I was 12, no, I'm just kidding. So anyway, I've been working with trauma response, so this was a natural transition for me to take my experience into policing. I have to say, though, you asked me a question earlier about policing, what do I do and how do I interact with the police? They had to adjust to a civilian, a person coming in and working with them to say, I think we should do it this way. So it was a challenge. There were 2 officers I worked with initially that really onboarded me across the region with police to introduce me, have them build rapport, have them get to know me. So it was a little bit of a challenge, but it's been widely well received. So back to the question you just asked me, I work with Riverside Trauma Center, so I've been trained by them in psychological first aid, which is a stabilizing method. I also do grief counseling for them. So if we have to do a death notice or something, I could actually do that, help the person through the policing. I have been trained in de-escalation 100 different ways to Sunday. I actually am on the advisory board for Essex County Outreach. And my role is the behavioral health role, but their substance use knowledge has also helped me.
Can you help us out and let the audience know what the Essex County Outreach actually is?
So
I know what it is. He knows what it is.
Yeah, but
my
everyone
viewers
else
don't know
doesn't know
what
what it is. Okay, so Essex County Outreach is actually a 34 police, so 34 police departments, police agencies, the sheriff's department, and community-based providers all work together to respond to substance use overdoses, to help bring treatment to the person. They have recovery coaches. They have a system that is called SIMS, and police departments across the region can put in a person's name who is high risk. Say they had an overdose in Beverly, but they're from Lynn. Lynn Police Department could see that this person had an overdose, so their team can go out to treat that person. So there's linkages. So Essex County Outreach has been instrumental in linking everybody together.
Nice. That's a good way of putting it. Now, Riverside, I'm very familiar with them. I took a couple of courses at camps with them also with the psych first aid. Very good classes.
Yep. So they also have MindWise as a company, part of Riverside.
That's coming up shortly. I'm going to just ask you about that in a couple of minutes.
Okay, then I'll wait.
But that's okay. No, you can talk about MindWise now.
Well, so the trauma center, let me just say, the trauma center is a team of about 100 people who have been specially trained by Riverside to respond to critical incidents in the community. So it can be for something really dire like the marathon bombing.
Yes.
It can be where a company, like a beloved employee has passed away suddenly and people are grieving. Communities that have like a tornado or some kind of critical incident. So we go out as a team and we help stabilize people, much like the debriefing and diffusing we do with the CISM team. It's very similar. And we've learned in behavioral health that if people can actually speak their words, what they've actually experienced, it helps take some of the power of the internal struggle that goes on away. And it gives people a voice, and it gives them the ability to sort of compartmentalize, and also the psychological first aid is about self-care. So we teach a lot about how do you take care of yourself when you're struggling with grief or trauma. And so that's what we do.
What would you like to see to make the greatest impact on mental illness?
So I think that Massachusetts, we were out west in one of our trainings, and so we were among people from Canada and the rest of the country, and there's a lot of great things going on across the country.
Yes.
But, maybe I'm biased, but I'm very proud of the work that Massachusetts is doing. We've come a long way. We still have far to go. So we have the community-based health centers where they can treat people for their behavioral health needs to divert from the emergency room. We have jail diversion clinicians that are embedded across the state. We have lots of agencies doing wonderful work. I think the biggest, there's also the Department of Mental Health has their behavioral health line. It's a 988 number that you guys will put on.
Okay.
But what I find happens is people don't know where to turn when they're in crisis. They will turn to police, yes, but a lot of times they don't, right? So they're trying to find a mental health counselor. They're trying to find the right kind of program or the right kind of treatment for whatever their need is. And so navigators are not case managers, but they're people that work for cities and towns that people can call and say, this is what I'm looking for, this is what I need, do you have any recommendations? So they have a resource list. And those are becoming more and more popular, and I encourage that. I encourage more and more navigators across the state so that people know where to call.
Oh, very well put. I'm going to come back to you.
Okay.
Ted's sitting there thinking he's off the hook. As I told you before when I first talked to you, I've been waiting months to find someone that can come on the show that can talk to our viewers about xylazine. I cannot interview myself. I'm not that talented yet. What can you tell us about xylazine? What is it?
Well, first, I appreciate your comments, and I did that training online with you in one of the M&M rounds. And,
I actually enjoyed it very much.
Thank you. And I literally ended the call online, and my phone rang, and it was David saying, "Hey, I want you to come." I was like, "Wow, that was quick." Yeah. But so xylazine is a new problem that we've started to see in this area. Xylazine is an animal tranquilizer. Okay. It is what vets use to sedate large animals. Mm-hmm. It is not for human use, was never meant or made to be used by humans. So it's got a street name called Trank, and basically because it's a very heavy sedation tranquilizer. And it got mixed into the drug stream a little bit, and what it does is it kind of makes it, it's not a narcotic. Okay. It does not respond to Narcan. So that's one major problem. Causes heavy sedation to the point that they've used the term walking zombies. The people that take it and use it become very dependent on it. Very severe withdrawals to the point that they're using it more frequently and more frequently. And they sometimes pass out and wake up 2 miles from where they were because they use the term like walking zombies. They're just tranquilized, they're just sedated. And so it's a scary thing.
Now, you mentioned this is a vet drug.
Yes.
How on earth is this stuff getting onto the street? Where's it coming from originally? Where are we finding it? How's it getting to the U.S.?
So it was initially mixed in with fentanyl, probably to try and create a longer high, a more euphoric high, and this started in Puerto Rico, and then it came into the U.S. through Philadelphia. Very high Puerto Rican population. Yes. The drugs were coming in from Puerto Rico with this with the xylazine added to the fentanyl. People didn't know that they were taking this. They didn't want this. They didn't ask for this. They weren't looking for it, but it became part of it. And then once they've had it, they become so dependent on it. So it started, Philadelphia I kind of call ground zero.
Yes.
They have a similar area like Kensington Street where there's people who are they just have to keep taking it over and over again. The withdrawals are so severe. And then it spread a little bit to New Jersey, and now we've seen positive cases of it in Beverly. It started in Gloucester and Salem, so we know that we're right in between there, and our drugs are tested occasionally through a program through Brandeis University, and drugs that we confiscate and they will test, and it has tested positive in Beverly.
I'm totally confused. I'm a businessman. I don't understand why you putting xylazine in an opioid when you're going to kill your customers. What is the point? Why is this even going in there in the first place? Does anybody know? I mean, what's it supposed to be doing for the person on the street?
Well, it's probably maybe cheaper to add it in, so from the business side of view, and also it creates that dependency, and it extends the effects of the fentanyl a little bit more. Fentanyl's relatively short acting. You know, they take it and it's in the system. It's out in probably an hour or two. The xylazine just extends that period a little bit so that they're more sedated, more euphoric, kind of almost trying to make it more like a heroin pop, because there's no heroin anymore. No one's growing poppies, and it's much cheaper to, in a lab, make some fentanyl. And so I think this was an attempt to try and make it seem a little bit more like the heroin of, a stronger version of the heroin of days past.
Now, when you take this, obviously it's affecting parts of your body. What's it doing directly to your respiratory system?
It's, again, very heavy sedation, doesn't respond to Narcan, so we train our officers to, treat every overdose the same. You check the pupils, it's always mixed in with something else. No one's taking xylazine straight, so we still give Narcan, we still have to make sure. So the problem is they're not waking up. So we would give 8 milligrams of Narcan and they're still not waking up. Maybe their respiratory rate has come up a little bit, their pupils have dilated a little bit because we've canceled out the narcotic portion by giving the Narcan.
Correct.
But there's still the xylazine on board, so we're still worried about heavy sedation, airway management, so they may need to be put in a position where you have to open up their airway, maintain their airway, possibly ventilate for them, or sometimes they could be breathing well on their own, but you just have to protect their airway. It could be something like just putting them in a recovery position, but you obviously can't leave this person, so now they need to be monitored and watched for several hours to make sure that they don't aspirate or anything like that.
I just wanted to dispel the rumor. A lot of people, and you are correct when you say Narcan doesn't work on xylazine, but you also said it affects the opioid portion. What I want to clarify is you've got 3 portions. You've got the opioid originally, you've got the fentanyl, and you've got the xylazine. At least you're knocking out the opioid portion by giving the Narcan. So it's not going to do anything for the xylazine, correct?
Correct.
But it is going to help me, at least with some of the respiratory, by taking the receptor off and getting rid of the opioid. So 1 out of 3, you're lowering the effect, but still with the xylazine depressing your respiratory system. You're not doing good, I'm sorry.
No. And the Narcan will reverse the effects of the fentanyl too, because fentanyl is an opioid. But yeah, like you said, it goes in and it blocks the receptor so that the Narcan, so that the opioid can't hit that receptor and kind
The only hard part of that is, and not to argue with you, but Mom and Dad have a box of Narcan, it's 2 bottles. Unfortunately, with the fentanyl, you might need 4 or 5 bottles, 6 bottles of Narcan. So giving the 2 bottles, it makes it hard on the layperson. Well, I've got my Narcan. My kid had an overdose 3 times. I saved him. Suddenly, fentanyl's introduced. And Mom doesn't even know fentanyl exists. Oh, never mind xylazine. So it's like, why isn't this working today?
I agree with you 100%. We do leave Narcan at the scene. We go with our recovery coaches and our harm reduction coaches and leave Narcan. And my big thing that I stress is you need to still call 911.
Absolutely.
You can't get in trouble. You can't be, like, if you call 911 to get someone help, you're not going to get charged. The needles you couldn't charge for a long time, but you're not, even if there's a little bit of fentanyl or something present, no one's going to be in trouble. Please, please, please still call, because they need to be monitored in a safe professional, like at the hospital.
Now, what the public doesn't know, Narcan is not a cure-all. It lasts for about 90 minutes, give or take.
Yep.
Unfortunately, the opioid you took is going to last longer. It's like an aspirin. You got a headache, it works 4 to 6 hours, you still get the cause of the headache. It's not going to go away, you need another dose. Why is it so important with that in mind, that your friend doesn't give you a dose of Narcan, you're up and running, oh, thank you very much, I'm going to go home now, get behind the wheel of a car. I live 2 hours away.
Right.
Do you see something wrong with this picture happening?
Absolutely. So, like you said, the Narcan can wear off before the opioid. So the Narcan doesn't destroy the opioid, it just blocks that receptor. So the opioid, fentanyl, whatever it might be, is still in their bloodstream. The Narcan wears off, that fentanyl or morphine or Dilaudid or whatever they took is still in their system and can rebind to that receptor and cause the problem again. To the point that now they've redone the protective custody laws.
Yeah.
Protective custody laws used to just be for alcohol. They've changed it to include all sorts of drugs now.
Nice.
So anyone that gets Narcan from the police department or fire or anything like that goes to the hospital to
Correct.
be monitored for a couple hours. And even to the point that if they refuse to go, we can place them in protective custody, use whatever is necessary. Usually my verbal judo is enough to get them to get on the ambulance. And no one, I'll be honest, most people don't fight it anymore. They're just, okay, I'll go up to the hospital, I'll sit there for a couple hours. They want to be safe.
So you're in a room with your friend playing cards, you took an opioid, you overdosed, your friend gives you a shot. So what we're saying is so important that somebody calls 911 for that person just because he's up and breathing really isn't doing anything. That's good for the moment, but an hour from now when that Narcan wears off and that kid's driving home, we can lead to problems. So what I'm trying to say, viewers, is if you don't need an ambulance because the guy woke up, please do not let him get in a vehicle and drive. Drive him to the hospital yourself. Of course, the best route, obviously, is to call 911. If you feel you don't want to do that, yourself, get somebody safe to get him into a hospital. Because you don't want him out there 90 minutes from now and the opioid takes over again because the Narcan wore off.
Absolutely.
So, injection. A lot of people still shoot heroin, which has your fentanyl and it has your xylazine. So if I'm going to get a wound, or there's always going to be in the injection site, I take the shot in my arm. You put the rubber hose around, put the band around. It's in my arm. There are side effects. There are wounds. Is it always going to be in my arm?
No, not at all. So with xylazine, and they're still studying the reasons behind this and everything, but xylazine can cause very serious wounds throughout the body, and it's not necessarily at the injection site. You may inject in your right arm and get a wound on your left leg. And these wounds, if they're not treated and cared for, become very necrotic and to the point of, like in Philly, they're dealing with a lot of people on Kensington Street with multiple amputations and below the leg amputations and everything from these wounds because they're not getting treated properly.
Chopping the legs off?
Unfortunately, it gets to that bad.
But I shot myself in the arm.
Yeah, they're trying to...
It's systemic.
Yeah.
Okay.
We're working with a doctor out of Thomas Jefferson University, Megan Reed, and we've worked with her through PARI, and they're trying to study like why is it happening elsewhere in the body. Starts as a little blue necrotic area and can quickly spread if they're not treated.
Okay. I have a slide from a xylazine class which I teach. This slide is courtesy of the National Medical Library, used with their permission. Warning, what you're about to see is graphic and may be disturbing to some viewers. So I hope they don't put this show on at 5 o'clock on Sunday night when the family's having dinner. You may now show the slide. Ted, Lisa, what are we seeing here? That's not good.
No, that's a very advanced wound from xylazine. That's very necrotic. You can see the black areas. That's all dead tissue. That's never going to be able to get back. They could attempt some sort of, obviously antibiotics, grafting, but a lot of wounds that severe will end up in amputation.
So basically I can stick my finger through the leg that's wide open, germs, bacteria.
Yes, I wouldn't recommend it, yes, but no.
Yeah. Right.
So basically, that wound is almost the least of his problems where he's got a wide open area for every bacteria. And these people aren't in a hospital setting. This person was under an area living homelessly, not the cleanest conditions. So every disease on the street, either from E. coli or anything else, on the street that they can pick up is going to be inside your body, which goes through every other spot of your body. And this, by the way, this was a 25-year-old female, which was picked up, brought to the hospital. Let us use her slides by permission to the National Medical Library to show people, that's why there's no face here, what it can come through. Now, if you on the street was to see this, what's the first thing you would do before putting them, say all the ambulances were tied up, never happens, and you need to get them to the hospital, they just want to ride in, you don't need lights and siren, what would you do? They took their fentanyl hours ago, so they're not really overdosing. You came across them homeless, they're having a conversation, oh yeah, my last hit was 5 hours ago.
Okay.
So it's not an emergency.
Right.
It's, what would you say to this person, and what would you do before putting them in your cruiser?
So-
Short of putting plastic everywhere.
Yeah. The most important thing is keeping it, they say, moist and sterile.
Okay.
So wrapped.
Yeah, we actually have wound care kits, usually for the much less severe cases, to try and prevent them from getting to this point. The problem that we're seeing is that is the stigma.
Okay.
People are letting their wounds get to this point because they're afraid to go into the hospital, because they're afraid of being treated poorly when they walk into the hospital. The stigma of being a substance use abuser, an IV drug user, is they would prefer to sit and let these wounds fester than go seek treatment.
Absolutely.
So what we need to do is change that attitude within our hospitals, or within our medical community, within our police departments. When I teach people in Narcan and xylazine now, I spend a good couple minutes on stigma, using the proper words. We're not saying the negative words that we used to use before. We're saying someone with a substance use disorder, someone who is in active recovery. We're using positive terms. We're not using the negative terms that I don't need to say that we've used in the past. So I think that's the biggest thing, is getting over that hurdle of stigma so that people are willing to go to the hospital to get treatment prior. And then the other thing that we're doing is we have we're starting with our public health department in One Stop, a van that comes into the city once a week. And they'll do testing, whether it's STI testing, but they'll also do wound care training. We have wound care kits that PARI has supplied for us that we're trying to get out there. We haven't seen it in Beverly yet, but better to be prepared than to be like...
It's around us, so it's going to end up there.
Now, I am not advocating in any shape or form, I say this, make this crystal clear, that you do self-treatment or treatment to your friend. Something like this needs a hospital, needs intervention, and it needs it right away. But if there's that person that is not going to go to the hospital, come hell or high water, there's nothing you're going to say that's going to get them there, and they're screaming bloody murder if you tell them I want to call an ambulance. For the parents that want to do something, which is better than nothing, while you're working on how you're going to convince the kid to go to the hospital, Ted, you're an instructor. How would you teach mom and dad to do something while they're convincing their kid to go? Mother never saw that before. Kid runs downstairs. She sees that lake for the first time. What would you tell mom and dad to do?
Take a deep breath.
Well, dad's secretly calling the ambulance.
Calm down. Try and not freak out, because I know that if I saw that on my child, I would be freaking out. So just try and then the other big thing is moist, sterile dressings, wrapping it up. Not tight, keeping it loose, but trying to prevent further infection, and also trying to prevent that drying out of it. We've worked with some people at PARI, that's their recommendation, is moist, sterile water, sterile gauze if possible, to keep it as clean as possible and keep it covered.
Okay. Now would probably be a good time to flip over to another logo. I'm sure half my viewers have now passed out, and 911 is ringing off the hook with about 30 people that have passed out on the living room floor. That's a lot better. Lisa, you thought you were off the hook.
No, I thought so. No, I'm just kidding.
Why is the work you guys are doing at Leahy Behavioral so important to the community?
Well, we are we're community-based hospitals, right? So the Beth Israel Leahy system is all over the North Shore. So there's Anna Jakes, there's Beverly Hospital, there's Addison Gilbert, so there's many. And like I said earlier, we've been dedicated to doing community work for a long time. So I feel like the collaboration between the medical side, the behavioral health side, and the other providers in the community, and policing, and things like recovery coaches, everybody working together towards the same goal. And Beth Israel Leahy is a collaborator in that way. So,
I'll go off the subject for a quick second. 25 years ago, I got a very severe issue. Wasn't drugs. I swallowed something that wasn't supposed to be where I ate it. It was something in the food. And basically I went into Winchester Hospital more dead than alive, literally. Projectile, you know what, absolutely very bad. It was a corrosive substance, and it could have killed me if I didn't hit the hospital. Thank God I lived 5 minutes from the hospital. And the whole idea was I got in, I got treated, and they basically saved my life. I mean, you have to thank the hospitals, the training that these people have had, and just what they do right away, what to do, right away what happened. They didn't know exactly what I swallowed. All they knew was it was a corrosive substance and how to treat it. So these hospitals are so embedded in the community, and just the level of care, I can't thank them enough. Which is one of the reasons I've been trying to get either Leahy or Winchester when it was Winchester, then it went over to Leahy, then over to Beth Israel. I've been trying to get someone on for 3 years on the show. But in an area, they really didn't do much with the drug program the way you have, so I'm so happy.
Oh, there's a lot of people doing a lot of work that you
Now it's really changed in the last 20 years.
Yes.
So, Lisa, do you have any final words for our viewers? A couple of you wanted to bring up earlier.
Final words. I feel like, I hope that people understand that the state, in many capacities, provider networks, the hospital network, Beth Israel Leahy, we are all, the state, DPH and DMH, we're all working towards addressing the problems, right? We're trying not to be reactive, we're trying to be preventative, and we've grown. And I want people to know that we want to hear your voices, but we also want you to know that there is help out there.
Oh, yes.
And don't get discouraged, look for it, you'll find it. Call the hospital, call the police department, call agencies around you, call the helpline, the DMH helpline, go to the community-based health center. If it's not an immediate crisis, but you need help, they can help guide you. So there's things out there, and I want people to know that they're out there to help. I get a lot of calls, people say, I don't know where to turn.
Exactly.
So
Ted, do you have any final thoughts? I can't say final thoughts, it's Jerry's thing, I'll get sued. Do you have any last thoughts?
Sure. I think the big thing that I would say is decreasing the stigma. If we can decrease the stigma around mental health, substance use disorders, they are truly medical issues. And just like diabetes or other medical issues, we tend to treat mental health and substance use disorders differently. And I think if people can decrease the stigma, there's medications to treat a lot of these problems. People need to be able to go into a hospital or talk to a police department and just feel comfortable that they're not going to be judged, that they're going to be treated kindly with sympathy and empathy, and just always, reach out if you're having trouble. It's important to reach out, and there's services, whether it's us from a police department point of view, from recovery coaches to everything else. Just we're here to help.
The help is there.
That's what our goal is, to help.
Yes.
Now, before our closing, I'd like to present each of you with one. Lisa, show on the bottom of your screen. Lisa, this is for you.
Oh, thank you.
Ted, this is for you.
Oh,
I
awesome.
appreciate you coming in.
Oh, thank you so much.
And the work that you have done and continue to do through both Beverly Police and Leahy's programs.
David, thank you
Thank
for
you very
having us.
much. Yeah.
You were a great guest.
Thank you.
thank
And
you.
you're a
I
great host.
swore years ago I'd never do a twosome. It was difficult, but you guys
We don't
tied
separate.
Yeah, no, you guys just tied in so well.
we got it down pat.
I had to do it.
Thanks.
Okay.
Thank you very much.
Okay. I would like to thank our guests, Ted Lane and Lisa Maccario, for appearing today. As always, thank you for watching. Please share this program with your social media friends. If you or someone you know is suffering from a substance abuse disorder, or now even a gambling problem, you can contact the Massachusetts Substance Use Helpline. Their number is 1-800-327-5050. Also, the contact information for Beth Israel Leahy will be on the bottom of your screen and at the end of the show. So give Leahy a call. The work that they're doing is absolutely amazing. Give them a chance to help your loved one out. This show can be seen on a rotating basis on Woburn Public Media stations and on demand at their website and on YouTube. As always, thank you to the staff of Woburn Public Media Center for making this possible. Please enjoy our closing theme, Rise Above the Noise by Fireheart, who was a former guest on our show. Through the credits for important contact information. For America in Crisis, breaking the cycle of addiction. My name is David Hunt. Thank you for watching. We have more shows lined up. We are back.
It is what we bear. The whispers that I hear behind my back are those who never lost a child, a friend, and so they lack a sense of loss, a peace that's gone with no return. Above the noise is how we cope, above the noise is how we learn. The most important things in life I found comes deep within the heart, the purest sound of those who won the fight. Now they found a life is true, a life so rich above the ground. We are people who care. Listen to the sound. Rise above the noise in the air. The sound not heard is what we bear. We are people who care. Listen to the sound. Rise above the noise in the air. The sound not heard is what we bear. The sound not heard